Welcome viewers to the final call. I am Abigail Ejay, midwife for the final call team. We are going to talk about malaria. Malaria, we all know, we take it as a very simple disease, but it has a lot of complications that can harm anyone. So today we are talking about malaria in pregnancy. Malaria, someone would ask, what is malaria? Malaria is a life-threatening condition caused by an infected mosquito which bites a human being and then introduce a parasite called Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, and then Plasmodium knowlesi. The parasite is spread through the bite of an infected mosquito, as I said earlier. The causative organisms, we have 4 types, but the most dangerous and common ones are the Plasmodium falciparum, that is the most dangerous one, and then the Plasmodium ovale, the commonest type we have, which causes a lot of malaria. Malaria in pregnancy. A pregnant woman who contracts malaria has a lot of implications on herself and then the baby. So, signs and symptoms of malaria. The common signs are fever, headache, chills, vomiting. The patient may tell you she finds it difficult to eat, she can't eat, the smell of food feels bad, the patient tells you she has chills, which of course causes a lot of harm to the pregnant woman and then the unborn child. The fever is as a result of high parasitemia. So the parasites will get into your bloodstream and then multiply. They leave harmful toxins, which causes a lot of problems for the woman. And one of those signs is a high pyrexia, a hyperpyrexia, which is a high temperature. Severe symptoms are impaired consciousness. So we have instances where the parasite will cross the blood-brain barrier and then go to the brain of the woman. It causes a lot of neurological disorders. So the patient may be hyperactive, the patient may be sometimes unconscious, the patient may tend to talk a lot, and then most patients will come with seizures. We have some patients presenting with difficulty in breathing, some will be having some form of bleeding, and then a pregnant woman who has malaria will present with lower abdominal pain. In fact, a lot of Plasmodium in the woman's bloodstream will cause the woman to get preterm contractions, which, if not treated early, will cause preterm birth. We have most of the women also presenting with bloody urine, and then some will come with some form of jaundice, that is yellowish discoloration of the eyes, the palms, and then the soles of the feet. We have effect of malaria on the unborn baby, that is the fetus. So we have stillbirth. The baby will be born without life. We have miscarriages. Because there is hyperparasitemia, somehow most of these pregnancies, the baby comes out and then there wouldn't be any life. Or maybe the baby will not grow to term and then it will be expelled from the uterus through the vagina. There will be preterm birth. So if a lady is, let's say, 7 months pregnant and then reports with a complicated malaria, you might want to find out what is causing her lower abdominal pain. If blood samples are taken to the lab and then assessed for Plasmodium, let's say Plasmodium, any of the types, if they are present, then it means that woman has to be treated. If left untreated, the woman may miscarry or bring to birth a child who is not term. We will have a baby born with low birth weight. So the baby is born preterm, meaning the baby wouldn't have the weight it is supposed to get. The baby wouldn't have a term baby's weight. There will be some form of congenital malaria. There are instances where babies are born with malaria. So they contracted the malaria in utero before being born. And then there will be fetal growth restriction. This fetus has had enough in the uterus, a lot of parasites hovering around it. So it wouldn't get all the nutrients, etc. that it needs for development. So there will be a baby with a very low birth weight, which is as a result of intrauterine growth restriction. So we have effect of malaria on the mother. When a mother is pregnant, what malaria can do to the pregnant woman. So we have maternal anemia. This woman wouldn't be able to eat. And then maybe somehow she wouldn't be able to swallow anything because there is nausea, there is vomiting. Mother wouldn't be able to take nutrients as someone who isn't having malaria. There will be a risk of miscarriage. So like we said earlier, the baby will be expelled. In this case, the mother will also experience miscarriages. The baby will not grow to term. The baby will be expelled at earlier stages. There will be complications like respiratory distress. There will be the malaria parasite too may be traveling to the brain, causing unconsciousness, a lot of neurological disturbances. Some may be talking excessively. Some may be hyperactive, moving, shaking, and then others too will somehow be unconscious for some days. Yes, it causes a lot of havoc to the woman. How do we manage malaria? So malaria, we have stages. We have the mild stage and then the severe forms of malaria. So a pregnant woman who has, let's say, one class of malaria parasite in the blood. This is determined at the lab. So a blood sample will be taken from the woman, taken to the lab, and then screened or filmed for these parasites. If it is a plus and the woman has no symptoms of nausea or vomiting, oral anti-malarials are good for them, depending on the gestational age. If the woman is vomiting and cannot tolerate anything orally, the woman is given IV anti-malarials. It also depends on the gestational age. Usually, the rest is managed symptomatically. So if the patient complains of a headache, whilst the patient is on anti-malarials, pain medications will be given to curb the headaches. If the patient is having nausea, the nausea will be managed with medications. If the patient becomes anemic, then it means that either the patient is put on hematinics to help regulate the blood, or the patient is hemotransfused. That is, the patient is given blood. Yes, the patient is given blood to help with the HB. As we know, anemia in pregnancy too is another dangerous problem for a pregnant woman and the baby. So how do we prevent malaria? So we have insecticide treated nets that are given to every pregnant woman on first registration. So that net is given to the woman at the very day she reports her pregnancy. Yes. And then secondly, the use of mosquito repellent. You spray your room. A pregnant woman with her family, the room will be sprayed for a while, and then later windows and doors are open to kill every mosquito in the room to prevent them from getting malaria. And then you have to wear protective clothing. Pregnant women who sell in the night, you have to put on protective clothing. You cover yourself up. And then additionally, you can add mosquito repellent creams to your feet and then your arms, your face, to prevent the bites from these harmful insects. Then pregnant women who are not G6PD deficient at 16 weeks are given a drug called XP, sulfadoxine pyrimethamine, intermittently from 16 weeks till term. So at 16 weeks, if you are not G6PD defective, you go to the clinic, they will give you SP, 3 tablets, and then that drug is given as DOTS, direct observed therapy. So you sit in front of your midwife and then she administers the drug to you. You take it right in front of her with lots of water. If you are G6PD deficient, you prompt your midwife so that you don't take these drugs, as it can cause a lot of harm to you. It's a sulfur drug, so any medication that contains sulfur shouldn't be taken by any pregnant woman with a G6PD deficiency. And then lastly, this drug is taken monthly, every month. So at 16 weeks, you take it. The following 4 weeks, you take it continuously for the rest of the pregnancy. Finally, if you are taking SP, there are patients who are on folic acid throughout pregnancy. You don't take your SP from your folic acid from the day you took your SP. So there will be a 7-day period in which you wouldn't take your folic acid. The reason is that we don't want to be feeding the parasite we are trying to prevent from causing harm to you. So if you have some of the parasites in you and you feed them with the folic acid, then you are doing no good to yourself. So you take a break for 7 days, and then after 7 days, you resume with your folic acid. So malaria is very deadly to a non-pregnant person, and then it becomes more deadlier to a pregnant woman. In this case, we are talking about a pregnant woman and her unborn child. So it shouldn't be taken like as if it is a normal or something so simple. It has a lot of complications. So once you are tested positive or you see any signs of malaria, go to the health center or the hospital for you to be tested and treated appropriately to prevent any of the complications. Thank you.